Hi, everybody. Welcome to the Insurance and Real Estate Committee's working group on pharmacist compensation. Hope you guys had a good month. Today is Tuesday, August 19th, 2025, and we're convening the meeting. Any remarks from Kara? Nothing? Great. All right, we're going to get right to it. Under number 3, discussion, we have services provided by pharmacists, and Representative Jill Berry is going to lead the discussion.
Thank you, Madam Chair. I will briefly detail what pharmacists do, and then, of course, you guys can offer any filler that I forget. So pharmacists dispense and handle prescriptions, but this is so much more than when you go in and just receive from what the consumer sees. There's a lot of behind the scenes. Pharmacists interpret, evaluate, and implement medical orders, process and dispense prescription drugs, manage compounding, ensure appropriate labeling and storage, and oversee medication safety. They must record patient information, review drug history, counsel patients on proper usage and storage, and maintain patient documentation. Pharmacists often provide other services like refill authorization, formulary compliance, and remote counseling. In recent years, Connecticut has passed legislation authorizing pharmacists to provide other clinical services, including prescribing hormonal and emergency contraceptives, offering HIV testing and treatment, and prescribing and administering all approved and authorized vaccines. And again, this is more than just a simple transaction. Pharmacists need to complete required training, and they need to screen and counsel each individual patient. And unlike the services mentioned above, pharmacists have no mechanism to bill for these services, therefore receive no compensation for these services from Medicaid or other commercial insurance plans. And without reimbursement, pharmacists struggle to offer these services, and patients face unnecessary barriers to care. And please fill in anything I may have missed.
Thank you, Representative Berry. Are there any other services that were missed? Does anyone want to elaborate or provide clarity on anything that Representative Berry discussed? Just press the button so that it turns on.
Nice.
There you go.
Here we go. Sorry. All the information are accurate, but most of it really focus on dispensing a drug and a product itself. What we're talking about here is more on a clinical services. Again, one of classic example is chronic disease management. Somebody has uncontrolled diabetes, uncontrolled hypertension. The same thing that any other clinic providers will provide, the pharmacist can do. And we have data from multiple studies over many years and multiple states that show pharmacists can improve outcomes, reduce the total cost of care, and reduce medication cost in a variety of settings. So it's just an add-on to what we classically have done, product-specific, dispense the medication, to more clinical interventions and clinical engagement.
Thank you. I was wondering if you can elaborate on that, how you're able to improve outcomes.
Again, also with diabetes, for example, there are studies show if you have a pharmacist managed patient with diabetes, or a patient group with diabetes compared to the standard of care, you can see a reduction in hemoglobin A1C, which is a whole, like how you control the disease. So you get, same with blood pressure, you get blood pressure in control. And all those conditions, if left uncontrolled, there are downstream consequences. You can find increase in hospitalization, increase in additional costs with additional medications to be added on. So there are every one of those diseases, just like cholesterol. There is a target cholesterol. Pharmacist managed group reach their target cholesterol at a much higher rate than any other would be a standard of care managed. Another example is warfarin, blood thinners. Patients who are managed by a pharmacist, you can have their blood thinner level is on a target which decrease bleeding complication, decrease hospitalization risk. So the improvement outcome piece is really depending on the condition itself. And for every one of those, we have specific metrics that we can clearly show there is improved health and improved clinical outcomes with one of those conditions. And all those studies also added the financial piece that you can spend less money on medications and you have decrease in total cost of care, because if you're going to go to the ED less. Right now, patients go to the ED because they can get access to a clinician. So if you see your pharmacist, you are less likely to go to the ED, less likely to have a complication from your disease. So there are downstream financial consequences, but we would like to see that as an access first issue, improve outcomes second, and then the financial benefit.
Thank you. And just to clarify a little bit, because I am, really looking to you guys to
Sure.
provide all of this information. It's not a space that I'm working in, but how does that work if you adjust someone's medication? And how is their doctor notified or brought into this discussion? And what if the doctor is in opposition to a pharmacist's adjusting of medication? How is all this worked out currently?
Well, currently you work under a collaborative practice agreement where there are parameters set either based on the condition itself or based on national guidelines. There are national guidelines that govern what is the first line of therapy in specific disease and what you add on. So all of that is governed under this collaborative practice agreement, which we actually authorized to do that in the state of Connecticut. This is not new. And part of that collaborative practice agreement, there's a communication frequency about what can change, how often, and so the providers are aware of the changes that happened. They clearly can object or say this is not what should happen, but all that is part of that protocol. Again, part of the existing approved process here in the state of Connecticut. We can do that today. We are doing it today in multiple settings.
Okay, and then okay, I've asked a lot of questions. Do we have any hands up?
Yeah, Marie Smith.
Marie Smith?
Yes, good morning. Just to answer a little bit more and elaborate Representative Wood's question about outcomes, we actually did, I'm Marie Smith with University of Connecticut School of Pharmacy. We did a pilot demonstration project with our Medicaid patients here in the state of Connecticut. We had pharmacists working as team members in the doctor's offices for about 6 months, and they saw the patients more intensely who had uncontrolled diabetes, uncontrolled hypertension. So they were an extension of the physician's primary care team. One of those patients may not see their doctor for every 3 to 4 months, whereas in between the doctor's visits, they met with the pharmacist to adjust medications, see if there were adverse effects. And what we found, kind of high-level summary, is and this was for patients who had uncontrolled hypertension, diabetes, GERD, whatever it was. We didn't specify any specific one disease state. So it was very much real world data. The average number of patients we had was about a little over 400. And we had pharmacist visits. The patients saw the pharmacist about 4.5 times over a 6-month period. When the patients came in, we measured whether they met their goal for hypertension, diabetes, whatever disease state they had. And then we measured it at the end on their last visit. So that was about 5 to 6 months later, where the pharmacist had met with them in between on a regular basis. And what we found is from first visit with the pharmacist to last visit with the pharmacist, there was a 28% increase in meeting their goals. So patients were very positive about that. The physicians were very positive about that. We also looked at total cost of care at the same time. And what we saw was what has been documented in many other places, as Sam pointed out. Total cost of care came down. And the biggest impact was on decreasing admissions to the ED, because a lot of patients who don't have access in the primary care world or can't get a visit right away will end up going to an emergency room for a primary care disease. And we also found drug costs decreased as well, because what was happening is there was a lot of patients who were getting medications but never using them properly, or just picking them up but not taking them. And over 6 months, if that continued in working with their physicians, we determined that maybe that wasn't a necessary medication. So we deleted a lot of medications that were just a waste. So those are just a couple examples here in Connecticut.
Can I ask, my experience has been going to a pharmacy and picking something up and not having a lot of communication. How are pharmacists communicating that you are able to do other services like consult on medications and have this bigger, broader relationship with customers that are coming in?
Representative-
First of all, sorry I'm late. I was stuck in Middletown traffic looking at the Connecticut River for about a half an hour. But so I'm Ed Schreiner. I work for Northeast Pharmacy Service Corporation. We represent 250 retail pharmacies throughout New England, about 120 in Connecticut. So to answer your question, typically what pharmacies will do is set up what's called a synchronization program. So this is people the pharmacies identify as needing assistance with their medication regimen to maximize outcomes. So what they'll offer to do is synchronize the meds. And this is not something the pharmacist arbitrarily decides. They'll take a patient aside. Typically, they'll flag a bag in a pickup section that when this person comes in, have the pharmacist come and talk. So the pharmacist will come over and explain what a synchronization program is. And basically what that is they take all the various meds, no matter who the doctor is or the prescriber is, and they synchronize them so that they all come due on the same day every month. And then, so the pharmacist knows when they're due, the patient knows when they're due. And once that process happens, it may take a couple months to get everything synchronized up. And there is a systematic way that it's happening all across the country. But once that happens and you have the patient synchronized, now it becomes a monthly routine where once a month, again, the pharmacist knows if the patient's adherent when they're due for all those refills. So about a week before the patient's due for the refills, the pharmacy will call the patient, and typically it's scripted. Have you been to the doctor? Have you been in a hospital? Has anything changed? Are you having any problems with your medication? So a screening process, and typically that will be done by a technician. But the technicians are trained so that if there's a red flag comes up, the pharmacist comes in and takes over that conversation right then and there. So this is really how pharmacists in a retail setting can do disease state management to assist the patient. So they're looking for problems. They're looking to make sure that people are taking their medications properly. If there's a problem, then the pharmacist, now we're 5 or 6 days out, right, before they're due. That gives the pharmacist time to be proactive and address a problem that may occur rather than being reactive after we've already had an adverse drug event. So that's really the advantage you have here. And then they can take that to the next level. So there's a patient, and we've seen hundreds of patients like that, every year in a regular pharmacy where they're going to multiple doctors. They may have diabetes, they've got high blood pressure, they've got heart disease, kidney problems. Sometimes it's overwhelming for a patient. So then they can take that synchronization to the next step and provide adherence blister packing. So now the patient doesn't have to worry about bottles and pills and what do I take? It's all pre-packed for them together in a pack so that in the morning you open your AM pack and there's your pills, and it's all set by the pharmacist, and that's all managed. So does every patient need that? No. But typically it's the more complicated patients, which are the more expensive patients for an insurer. That need that service. So to answer your question, the pharmacies will routinely offer that when they see someone struggling or they see that they're non-adherent, they're chronically late calling for their refills, and they'll offer that service.
Thank you. That's really helpful.
So I work in
Sam.
a hospital setting, and we do it slightly different from what Ed described. So the initial encounter can happen behind the counter where you identify patients that need support, or you get a referral from a physician because the goals of diabetes or hypertension is not being met. But the follow-up encounters, the calls from a technician, the meeting with the pharmacist to go over medications, changes, adherence, all that done in in an appointment that is made either in person or virtually in a quiet setting that really allow the pharmacy dedicated the time to really modify the therapies to reach the goals. So at least in all our collaborative practice agreements are designed with that. After the initial referrals, there will be a one-on-one meeting with the pharmacist and technicians along the way for that medication management session. Slightly different approach.
Thank you. We have a question from Sue Halpin.
Hi, good morning. First, I want to say thank you to the Office of Legislative Research for all the incredible work they did. I found it really, really useful, perhaps raised more questions to have answered, but I think it was terrific. And, you know, we're still in the process of gathering more information from the insurance perspective, but as I hear you talk, you're using terminology that's familiar to me and that I'm just trying to understand still kind of the way that you're practicing today, because it sounds like you're doing many of the things you're seeking to do today. You're talking about working under a collaborative practice. And so you're doing these services or providing these services for a value add, I'm assuming, for each of your retail pharmacies, right? Or as a value add to that collaborative practice arrangement. So I'm just trying to understand, are you in fact being reimbursed for these services today that you're providing? I'm having a hard time wrapping my head around, you're providing all of these value adds, and I know you're advocating for more clinical responsibility in addition, but it sounds like what you're describing today is within the scope of what you would hope to expect if you went to a pharmacist or a pharmacy. Am I making sense?
Yeah, you're making perfect sense. So yes, pharmacies, first of all, not all pharmacies are doing this. Some of the more progressive pharmacies, there's a group in Connecticut called Community Pharmacy Enhanced Service Network, CPESN, and we have a Connecticut chapter. And that the process I described is mandatory for those pharmacies. So right now, to answer your first question, no, they're not reimbursed for this service. They're doing it for two reasons. They're doing it, number one, to improve patient health, because they see patients struggling every day. Number two, there is an economy of scale for a pharmacy who can do that. Because again, they'll know when all those patients' medications are due. So instead of having 500, and I've seen a pharmacy in North Carolina who, before they started this program, they had $500,000 worth of drugs sitting on their shelves every day. They got 80% of their patients synchronized in their pharmacy, which is that's a high target number. And they got their average inventory down to about $80,000. So right there, it's making that business more efficient. Rather than them holding the drugs, the wholesaler's holding the drug. Because again, they're 5 days out. They only order it after they know that patient really needs it and is going to use it. So right there, there's a business model that makes sense for this. And that's why most pharmacies are doing it right now. But there is no reimbursement.
So there's a value added to the pharmacy to do this for themselves, to make their own operations more efficient, to be perhaps a value add to a payer that might be looking to encourage this type of service, to encourage these kinds of operations. I guess you're still in a competitive environment, right? The retail pharmacies are in a competitive environment where they're competing for customers, potentially competing for payers. So I guess I'm just trying to understand a little bit that what are we looking, what are you doing because it's in the best interest of the pharmacy, the best interest of your pharmacists, the best interest of your customers, right? To make you a competitive entity within your own field of operations. And then what is, you know, from a policy perspective, what is the value add of taking, and I think the step is already there because you're doing a lot of this, right? Because the scope of practice is there. But what is the value, I guess, of taking that next step and looking at making the pharmacy a clinical participant? Because when you're a clinical participant, as I understand it, and starting to learn more about this, there's a lot that you're going to be required to do. You know, I think Representative somebody, I'm not sure which one of you, I'm sorry, mentioned, you know, how do you communicate back to the doctor, right? Do you keep a medical health record, you know, for the patient that can then be sent out to the 6 different providers? And I know, you know, when we're talking of the quality is the big focus right now, everything's about quality. And the pharmacies that I've been in are very, very busy operations. I mean, there are usually lines at the counter. There's a separate little counter to get a consultation if you request one. But it's not the same as being in a doctor's office, at least in my experience. So I'm just trying to wrap my head up around what we're looking to invest in. And it sounds like there's different models out there today. And are we looking to make them all the same? Are we looking to put those same requirements that you just spoke about for your group across the board to all of the pharmacies in the state as we're looking at the clinical operations? I'm just trying to understand that basis. And a lot of these OLR reports are connected, and I know we've got them broken out on the agenda, but we tend to talk about payers as one entity, right? As one group of, you know, of payers. You know, the largest payer probably in the state of Connecticut is Medicaid. Then following that is going to be perhaps, I don't know, between Medicare and a combined Medicare Advantage and Medicare, which the state doesn't have any, you know, purview over. And then we move again into the self-insured market, which is really employer-sponsored care. The employers are making those payment decisions. The carriers or the third-party administrators are administrating what the employer wants to do. And then lastly, you probably have that small, fully insured segment of the market. So I just, as we have these conversations, we tend to talk broadly about getting coverage, about getting reimbursement, but that reimbursement is depending upon the market that you're serving. So I just wanted to, I know I'm going to start every conversation, so I beg your indulgence as I do that, but it really does tend to get lost in a lot of the conversations about policy. So I just want to reiterate it for the group. So there was a lot in there. I apologize, but I appreciate any of your insights.
I can jump in if you don't mind. So I appreciate what you mentioned at the end, that this is going to be pair specific, and we tend to generalize, and so that's a fact that we all acknowledge. I just want to go back to the comment that you mentioned about the services you already provide today. That's actually not the standard. So Ed talks about what I assume out of all the retail pharmacies in the state, a small fraction. The same with collaborative practice agreement is not done in every hospital, every clinic, everywhere. So we're talking about pockets of these activities. And if we want to expand that activity to really accomplish the goals of the bills that were passed in the past, provide better access, we have to create a platform to make that programs or structure actually thrive. Right now, we heard from Marie Smith last time that we're already allowed to prescribe birth control. And in order to able to do that, you have to get training. I think UConn School of Pharmacy provide that. And so far, nobody is taking this training because there is no financial incentive. There is no ability, unless you provide me with a way to fund that activity. There's no way for that pharmacists who are very busy behind the counter. And the last thing I'm going to ask is I would hope everybody here to kind of change their vision of how this is going to happen. We are not saying that a patient will walk in to a CVS or Walgreens or whatever the pharmacy is, and all this interaction will happen in real time behind that counter. This is not how it's supposed to work. It's supposed to be just like that physician office atmosphere where you actually have a conversation about clinical management of very, very complex patients. So it cannot happen in the same environment. And in order for us to free up pharmacists to engage in these conversations, there gotta be a financial model to support it. It's not gonna happen. So again, this is really pockets of small activities. Everything we mentioned about outcomes, it's coming from UConn School of Pharmacy. It's coming from big health systems. Trinity Health has something. So it's really pilots across the country, but not. I don't want to get everybody the impression that this is happening everywhere in Connecticut, and that's what we do and why we ask for something more.
This is very helpful. I believe Senator Lesser had his hand up for a while. Representative Meskers, you have your hand up?
I do, thank you. So I'm trying to build on the conversation in relation to a business model. Because I think what you're talking about in delivery of service and improved outcomes, I don't have a problem or could find an objection to it. But in the conversations we've had over the prior 4 years, I think or 6, I can't remember if it's been 6 years on insurance. But the conversations have been, in many cases, arguments or discussions about parity of payment, which in many cases works out to be equal pay for various levels of practice. So when we talk about the proposal here and in financial incentive, here would be my concerns. I have the most expensive healthcare system. Being the United States, is the most expensive healthcare system in the world on the cost per patient, with not necessarily the greatest of outcomes. So I hear what you're suggesting here, which is better outcomes. I guess within the business model within Connecticut, I think it was a veiled question from one of the other speakers. Are we talking about an incremental payment model, or are we talking about diversions in the payment model to incentivize the pharmaceuticals, which, if you want to think the pharmacists who you think are boots on the ground, to have a more robust engagement with patients? So it's a question of, is this something that both the insurance industry and we as legislators should think about to provide the right incentives? So complex cases, people who need closer monitoring. So instead of going to the physician and instead of going to the doctor's office, not only is the outcome better, but is the cost per encounter or the cost per service lower? So am I transferring a payment, may potentially even reducing a payment that might go to a doctor's office and putting it into the pharmacist's pocket? And that's kind of what you're envisioning on this model. Because I think
Representative Meskers, do you
Yep.
mind if I just jump in a second?
Yeah.
I believe you're on C and we're still on A, the services provided by pharmacists.
Right.
Can we revisit your question when we're on the payment model?
Okay, perfect.
Okay, sorry
Yeah,
about that.
thanks.
I just want to keep us focused.
I apologize. Go ahead.
We have a lot to get to today, and your
Yeah.
question is really important, but we are going to cover the payment model in C.
So I will retract my question. Thank you.
Okay.
Come here.
Thank you. I apologize for that. Senator Lesser.
Thank you, Madam Chair. Just a question. First of all, Ed, sorry about Middletown traffic. But just specifically about the services. So I know we've talked about a bunch of health-related services here, but we haven't talked about cost. And I'm just wondering, in terms of providing advice to patients, is there, obviously one question is looking at, NADAC or WAC pricing and sort of like what can we do to lower costs? But is there any incentive to pharmacists to save money anywhere in the system? Is that do we provide any benefit to them? Should we not do that? Is there any sort of interaction between cost and the quality of healthcare that we should, be mindful of?
I believe Sam addressed that in his answer, but
Ed talked in our last meeting about value-based agreement that will accomplish that, and Ed, you have more information about that, so I'll defer to you because I think it's relevant here.
Right. So we look at it, Senator, it is twofold, and we're kind of are getting into the payment model that I did send a thing, but I'll just briefly explain it. So before I do that, I'd just like to address a couple of things that Susan said. So yes, there's only a few pharmacies in the CPSN group. They're a clinically integrated network. So think of it as an ACO group or a physician practice group, but a pharmacist, and there's a legal structure that makes them legal to work together. The second question you had asked about was, how does the data get reported in the community pharmacy setting? There's a function in the pharmacy software called an e-care plan, electronic care plan, that is integrated with physician platforms so that they can go back and forth. So it's not just faxing and phone calls. This is how pharmacists and CPSN report out, and it's doable in any pharmacy that's got a software. It's a national standard. It's not a CPSN thing. So that's two little segments. The third thing is we're looking for payment because not all pharmacists can financially afford to do that. And it's a valuable service because there's a value-based add-on that's a benefit to the payer. So to answer Senator Lesser's question, does the pharmacist focus on reducing drug costs? No, not that's not what we're talking about here. We're talking about value-based care that a pharmacy system can provide that lowers the total cost of care. And that's where the savings are. So the savings, and now it may be that there is a better, more effective drug that the physician, the prescriber, and the pharmacist and the patient can all work on to do together. But that's not the sole focus, isn't the cost of the drug. Basically, in the system we're talking about, the drugs build a patient file for a pharmacist to provide a service. So the prescriptions that the pharmacy are filling aren't the focus of what we're talking about here. What we're talking about is all those prescriptions give the pharmacy a base of patients to work with. And so whether a physician says, hey, this pharmacy is doing a great job, I'm going to send more of my patients there, that would be a benefit to the pharmacy versus sending them somewhere else if they needed that help. So no, we're not really looking to address the cost of the drug. We're looking to address the cost of the care. And so you tie all of that in with a value-based contract where the pharmacies are paid for performance. So they're at risk. If you don't meet the goal that's set up with the insurer or the payer program, there is no payment or maybe a reduced payment unless the pharmacies show value.
So I
Okay,
pre-
thank you, everyone. We're going to move on to B. We have a lot to get to today, so I'm going to try to move the discussion along. B is a review of other states' regulations. Representative Pavlak D'Amato is going to lead this, but I know that Jean Cronin, who is out in the audience, was very interested in this. So Jean, I don't know if you wanted to, participate in this discussion on the, regs and laws from other states. This was.
I think our members were sitting task force.
Okay, good. All right, so Representative Pavlak D'Amato is going to address some of the stuff, and we didn't do every single state. We just did, some of our neighboring states. So we're happy to talk about states that are also not on this. Representative Pavlak D'Amato.
Thank you. So as I don't know if everybody got a chance to look at the chart, and it is a variation of, for people in the audience, commercial, Medicaid, and some alone, some a mix, including then whether it's for specific services or any service. Connecticut does fall into the seven or eight others that have no payment, which also in line with Arizona, South Dakota, Alaska, no, not Alaska, Alabama, Florida, Georgia, Maine, as well, don't have a specific pharmacist pay model. Most of them, as you can tell, what I found was that the language of other states included that the service was within the scope of the individual's license, that the plan would have provided benefits if performed by a doctor or physician's assistant, and that some also had language that included the pharmacist as a participating provider. So I think that's where I'd like to get some input as far as some of the language on other states and what everybody thinks as far as the scope, and especially part B that I mentioned, as far as the plan would have provided benefits if it was performed by a doctor or physician's assistant. I'd love to get some feedback on thoughts of, again, the varying language and what you think would work in Connecticut. Thoughts?
Hold on, let me just check. I know the Texas model was mentioned, I believe, in past discussions. Is that something anyone wanted to further talk about?
Sure, I can. Okay. I'll start. Yeah.
Ed?
So our group, we did look at a bunch of bills, and you look at NASHB, which I'm not sure where that, if that's where you're, they track hundreds of bills all throughout the country, and it's very, there's a lot of different things going on in a lot of different states with a lot of different focus. So we've identified a couple of states who have what we think are strong bills, and what makes them strong is they're not mandating specific things. They're more broad in scope to give insurers, payers, pharmacists, hospitals, doctors, patients the most opportunity to take advantage of all the stuff we're talking about. So Texas is one of those. Washington was another that I thought we thought, I shouldn't say myself, but a number of us had looked at, that had very good wording, because it's not like mandating one little thing. So if we get, for instance, when we had our first meeting, we had I think there were 4 different things based on the current scope of practice. And everybody said, let's not focus on minute details. Let's get the overall system and principle down. And that's what Texas and Washington State, that legislation does. If you read it, it's very simple. It's a couple of sentences, and that's it. But it just, so it gives the whole healthcare system the opportunity to focus on what they want to focus, rather having to come back next year and say, well, we want to add this, we want to add that.
Yeah, and I'll just read the Texas description, and this report is in everyone's calendar for today, and it also was emailed out, I believe, on Friday. It prohibits commercial health plans from denying reimbursement to a pharmacist for a service or procedure within the scope of the pharmacist's license to practice pharmacy, so long as the service, 1, would be covered if provided by a physician, advanced practice registered nurse, or physician assistant, and 2, is performed in strict compliance with the pharmacist's license and scope of practice. Anyone want to elaborate on that? Sam?
Yeah, this is really in line with other states. Texas is one, but Washington is another great example, because it's been in place much longer, actually. So we will look at Washington, and they have that approved a while back. So rather than focusing specifically on the 4 conditions that we are authorized to do: birth control, HIV, influenza, and vaccine, the idea here is that anything we are authorized to do under our license, that will be in scope. And that's the language really that ideally should be there, because if we wait for every legislation to add one condition, it would be just an overwhelming process that's not going to get us where we want. So that if we just simply use what we authorize to do under the scope of our license to practice pharmacy, that will cover diabetes, hypertension, asthma, and everything. The other thing about reimbursement, the goal is here to provide service to patients and improve outcomes, not to provide a cheaper alternative to physician care. That is really not the intent. So we want anything that is covered by other providers. If we're going to provide the same service that is provided by other providers, it should be covered in the same manner if a pharmacist providing it. So it's really the 2 cornerstones of what we're asking for here. Anything we are allowed to do under our license and be treated like any other providers providing the same service.
Now, I have to say, I completely agree I am very much against naming specific things in any type of language. It doesn't make sense. And that's not, again, when you look at our forefathers and how they drafted the First Amendment, the Second Amendment, they didn't say by newspaper, right? Or whatever the means was. It was a broad application of an idea. And again, that's, I think, good governing. But I did find interesting that we usually, when we draft language and have bills here, it's allowing somebody to do something. Again, not what I like. As opposed to here, it said payment shall not be denied, right? Or benefits shall not be denied. So it's kind of the opposite of what we're used to doing. And I was wondering your thoughts on, I saw that in several states. And I'm not sure if you see a difference in that. But yeah, I'm looking at one, may not deny reimbursement. And it's strange because we don't do it that way, but it did concern me that some of them were, a few of these were from 2020 and a little bit later as opposed to some of them that were earlier. I think Washington, like you said, was 2015. So I prefer to look at some states that are a little older and then have some data. But any thoughts on that language and any concerns with the kind of difference in wording it?
Yeah, I do have a thought on that. So at first read, it looks like we're mandating something, and we're not looking to mandate
Right.
anything. We're looking to it's more recognition of the pharmacist as a professional who can provide us some of the same services that a physician or an APRN or others that are paid for those same services can do. So the law isn't mandating that every pharmacist in the state is going to get paid. What the law is saying is we see pharmacists as being capable of doing these clinical services. So are all pharmacists going to bill for these things? No, it's only going to be pharmacists, the dispensing pharmacists. You're right. They're too busy. They're not going to do this. They can't do this and do it well. So, but with the financial resources to dedicate a pharmacist to providing clinical services who goes and gets credentialed and so an outside source says, yes, this person is capable and trained. Now we have a person who can provide these services comparable to what we're already paying for in the system. So it should not be an incremental cost for a healthcare plan. And if the services that the healthcare plan, if the healthcare plan or the payer or the insurer wants to target something they want the pharmacist to work on because they think that's going to save them money, and ideally in the CPSN world, we're going to save you more money that's going to cost you to pay us. So we're not a cost burden. We're enhancing your cost savings. That's the theory behind it. But again, it's not mandating. It's just saying that, pharmacists who are credentialed are capable of doing these services clinically. And you shouldn't say, well, we're not going to pay because you're a pharmacist. And there's nowhere in the statute that says pharmacists can do this. So that's the benefit of those short laws. And again, not looking to mandate, looking to open up possibilities for pharmacists to work with healthcare plans and insurers and payers to help them on their side save costs, because we understand that too.
Sam?
Hi, Sam Hollemeyer with PCMA, the PBM Trade Association. I agree with that. Mandating isn't the right word. Maybe allowing pharmacists to practice at the top of their license. I know it's wordsmithing here on the fly, but I agree with that. But mandating isn't the right approach, but allowing pharmacists. So we could allow pharmacists to do, diagnosis and working all that stuff, but mandating them, I agree, that shouldn't be the right path.
Yeah, I mean, when we usually do it, it's like shall, right, or may, I think is the difference. So but again, to me, the language always ends up being, you want to make sure that, again, we're not going back every year and then finding these big mistakes. And I know we always try to avoid them, but then we end up still coming back and dealing with it. So it's nice to get it done the first time, right? So.
Okay, we are going to move on to the next letter, which is C, payment model. And Sue, is this something you wanted to just lead the discussion on?
Sure, I'd be happy to try. Thank you. I think, we've already discussed a couple of things in terms of the different payers and the requirements for each of those segments of the market. I think OLR did a really good job on describing really some of the elements that need to be discussed, I think, in order for pharmacists to potentially bill, which is how is the definition of provider articulated in statute? In some places, it comes under the Pharmacy Act. In other places, it doesn't specify a definition for a provider for purposes of the act, but it certainly appears vague generally. What Connecticut law does basically say is that a pharmacist can order, prescribe, and administer. So it seems like, you know, if we go forward here, we have some definitional issues that we have to go around or work around. And then you know, the OLR summary does a great job of talking about, you know, the requirements for any provider to bill an insurance, what kind of form it has to be on, timely filing of payment, that it has to be a clean claim, has to include all of the information. And then I know credentialing is something that is a separate category here, but I think that's also, you know, another issue. There is the concept, I think, when we're talking about third-party models to bill of you know, can a pharmacist be allowed to bill? I think that's the conversation we had. And then there's the next step of how does a pharmacist bill? I think we heard today the act is not, or the legislation is not intended to mandate, it's not intended that every pharmacist be included. But when I think about this, I think about, okay, in-network versus out-of-network. Are you going to an in-network pharmacy, but the pharmacist may be out of network? How does that impact a consumer who has a high deductible plan, who may have a different deductible for in-network and out-of-network services, right? What are the mechanics that we would have to work around in order for a pharmacist to, you know, bill under that kind of clinical operation? And then when we go into that, you know, what diagnosis codes are we using? I don't know, you know, for some of the things that you described, if there is a diagnosis code for that kind of billing operation. Now, that said, the value, you know, value-based payment is where I think the majority of folks want to go. Some of the things that I've heard described here, you know, seem to make a lot of sense if you're talking about value-based payment arrangements. And if you're looking for the opportunity to contract with carriers, with a network of pharmacists, or are you talking about individual pharmacists? I think there's a lot of mechanics that are involved and how that billing would actually happen. And I would be curious if you've particularly, can't see that far away, Ed, I would be interested, have you had any conversations with payers about entering into a value-based payment arrangement already?
So yes, yes,
Okay.
yes, and yes.
Okay.
So yes, pharmacists need to be credentialed.
Okay.
And that's farther down. There's
Okay.
mechanisms to do that.
Okay.
Yes, pharmacies have to be able to bill using insurance language. So it's not like filling a prescription. E-care plan functionality takes CPT codes, which I'm not sure. I believe Marie Smith from UConn was sending in an example of a value-based claim. I've been away on vacation, but did that get to the
Marie,
committee?
were you able to send that in?
Yes, I think it went out this morning. I think from Allison.
Okay, if you look at Allison's email, I believe it was 9:57 a.m. It should be in there.
Okay, so in that, I put an example of a CPSN program, and it's a template marketing program. So I've marketed around in New England. Unfortunately, because we don't have a law like this in place, New England is behind the rest of the country, but it's happening everywhere else in the country. CPSN, I believe they've done like 400 or 500 value-based contracts over the last couple of years. We're talking 16, $20 million. So yes, it's doable. We want to bill using CPT codes, which is what's in my example. And what we came up with was a list of codes that the American Pharmacists Association said, these are the codes that translate best from what a pharmacist is doing to a report that goes to insurers so they can understand it and it's the same as everybody else. So you don't need to build a whole new infrastructure for pharmacists. They want to use the same plan. So that should alleviate all those barriers. Is it going to happen? Yeah, probably, especially in New England because we don't have the full experience. So, but it can be done, and it's being done all across the country.
So through you, Madam Chair, Do you have, do you have any contracts with payers currently in Connecticut, value-based? And if you don't, is the reason because they feel like they can't do that here because of the law?
So that is correct. We don't have any here in Connecticut. I have had extensive conversations with a large ACO who actually we put in a grant for CPSN to fund additional training for our pharmacists to bring them up on speed of everything. And the ACO gave us a letter of intent saying that if we get this in place and get this going, they want to contract with us. And we've talked about a number of different, I'll call it a pain point. And it's not my pain point, it's their pain point. It's something that they're having problems with financially that they think we can help them address.
And in terms of the hospital-based systems, are you in value-based contracts today?
We are in value-based contract, but not pharmacy-specific value-based contracts. It's usually for the across institutions, so multiple discipline work on a care plan to provide value for a patient population, but not specific to the pharmacist. For the same reason that we do have a very extensive credentialing process, so that happens today, but there is no mechanism to bill or engage in that agreement for pharmacists only. Just no structure for that today.
And I also just wanted, Sam and I talked about splitting some of this conversation, so I just wanted to invite him to make any comments.
I have a question more than a comment. So Ed, I go to get a flu shot now in Connecticut. Can you walk me through the pharmacist side of stuff on entering it in the system, computer, talking to the payer? Can you just walk me through that?
Okay, so we can talk about that. So flu shot is a service that everybody's understands a pharmacist can do. First of all, there's no clinical payment for that, but the pharmacist does a lot of clinical activities. So the first one is we're going to screen. We'll talk about a flu shot. So does the patient meet all of the federal criteria to be eligible to get that flu shot? Is there any reason why we shouldn't give that flu shot? For instance, in a pregnant woman, we wouldn't want to give them a live nasal mist. So the screening questionnaire is going to say, "Are you pregnant?" And if the answer comes out yes, the pharmacist automatically says, well, you're not eligible for this. So there's a screening that goes on. So that's really a clinical service. There's all kinds of other vaccines, outside and COVID. So COVID vaccine, the criteria are changing this year by age and by disease. All of that gets screened. So there are people who don't get, they're screening. Sometimes it's not appropriate for a vaccine, but there's nothing in there that addresses that or catches that or document that on the pharmacy transaction side. So the pharmacy transaction side is ignoring that and saying, okay, the pharmacist has done the screening. This is good. We're good to go. So the pharmacist fills the prescription just like any other prescription. There are a couple other fields in the software where they're going to put in, instead of a dispensing fee, an administrative fee to give that vaccine. And so it's technically it's done, computerized, and it's submit, and the claim process, it comes back. And I don't think in 35 years when I owned a pharmacy, I don't think I ever had a vaccine claim get rejected for any reason. It's pretty much recognized as a good thing. And so the pharmacist goes and gives that vaccine, and the claim is transacted for that administration. But again, all that stuff that led up to it, all that screening, isn't captured anywhere unless we do an e-care plan that says, I talked to this patient and she wanted the nasal spray because she's afraid of needles, but we found out that she's not eligible, she's not pregnant. We explained everything to her. We did some education and management, and we did all this stuff. We gave her the appropriate vaccine. That's what we're talking about here today.
And if I may add a comment, Sam, this is assuming you walk into the pharmacy saying, I want a flu vaccine. There are patients that don't know what they need. You can walk in and say, I'm 65 years old. I have an autoimmune condition. I'm on all this meds. What vaccine do I need? It's totally different from anybody that's well-educated, know exactly what they want, healthy otherwise. We're talking about the patients who need care and don't know exactly what they need. So Ed described somebody who knows exactly what they want, but we have patients that, 65 or 70.
I apologize, Madam Chair. I probably should ask you to ask Ed to do that, so I apologize.
We have Representative Mesker's hand up. Okay, while we're waiting for him, Sue Halpin.
Thank you, Madam Chair. I was just trying to look at back at the bill from last year to see if we ever got a fiscal note on any of these proposals. Because I'm hearing a couple different things as we talk around the table, which is a good thing. And I'm not saying I'm opposed in any way, shape, or form to what's being discussed. I think just more information is really key to how we move forward. But I'm hearing kind of two different things. I'm hearing the interest in working through value and what other value add pharmacists can bring to the table. And then in the example we just talked about, I'm hearing, okay, the pharmacist today is doing things as a matter of routine that they should be paid for, or could be paid for or want to be paid for. And I think those are really, I put them in two different categories. So recognizing that there may be clinical value going forward, et cetera. But if we look at the here and the now, and many of the carriers today are in the middle of a rate review process where they are getting it is very contentious in terms of the rates that they have proposed to pay for clinical services, for increased use of clinical services, and for higher unit costs of clinical services. And they are subject to rate review by the Department of Insurance. So anything that has the understanding that there may be long-term solutions, we have today issues that everybody's going through. So I think we need to look at what the cost implications of this would be, again, not to oppose, but just so we all have an understanding of what that would be going forward. And Madam Chair, if I could make a suggestion that maybe we take the proposed legislation of last year, if that's the proposal that you're still promoting, and ask for a fiscal note from the Office of Fiscal Analysis for commercial insurance as it applies through the healthcare exchange, through the ACA, to Medicaid for DSS, because we can't leave that. I know that's not the cognizance of this necessarily this committee, but I think it's really important to the discussion with almost 1 million people insured under Medicaid. And then thirdly, it would be great to know, just use the state employee plan as an example of a large self-insured employer-sponsored plan and what the impact would be to those 3 entities, just to give the task force and the legislature, as this moves forward, which I assume it will next year, more information right up front in terms of what the potential cost or cost savings might be going forward. So just put that out there.
Madam Chair,
Ed?
you might address that. I think that's a great idea, Susan. But what I would say is again, we talked about value-based contracting. So you have to evaluate each program that an insurer wants to do separately, because they're all going to have separate goals. So I sent in just one example of a potential value-based program, and with your indulgence, I just kind of explain a little bit of it, which will answer Susan's request. So in this particular scenario that I sent in, which is a program that's been used elsewhere, and this is just one.
Ed, was this part of the email at 9:57?
It should have been. I was on vacation, so I came back for this. I haven't seen.
All along, Allie, what file is he? What's it called? What's the name of the file?
This is Marie Smith. It's a file that's labeled Insurance Savings, FFS, and VBC model.
Okay, so, and we'll just move into the insurance savings discussion too at this point.
It's
Yeah.
actually.
Why don't we just move right into that? And Marie, please feel free to participate in this as well. But what page of that, Ed?
Marie, what page?
I'm not sure if you have it. It's at the very top. It's an example. You're talking about the Elevance example?
Yep.
Yep. So it's the first, right at the very top, page 1.
So is there any way we could pull this up? Yeah, why don't you share your screen? That way we can look at it and they can talk through it with us.
So this is just what this is, a report from Elevance Health, who's affiliated with the Blue Crosses. They were running this a program, a multi-state program. I believe that was with Medicaid managed care organizations. So you talked about different kinds of programs. That's what this one was about. And this is their paper that showed the savings that they found with a program that they designed to work. So that's my point is Elevance designed the program. They used and they own their own pharmacy benefit manager, Carolyn. They said, well, we want to look at these patients. And so they looked at the claims data, found the patients, then they sent the patients to the pharmacies to do the intervention, which is what they were paying for. And what it showed there is with the it reduced inpatient readmissions by 30%, ED visits by almost 18%, less trips to the primary care provider for emergency services at 14.2, and you see down. So there's where they made their savings that paid the pharmacy. So that's the first part of this. And that's what Elevance, that's again, an insurer's study of their own system based on a contract that they design to work with pharmacies. Can we squeeze it down again and maybe go to the next? Okay, there, right there. So this, and I'm not saying this is the model they use. I just took a very simple model of how could this be done. This is an example. There's numbers in here. They mean nothing. They're there for illustrative purposes. I randomly made them up. But when an insurer is looking for savings, they're going to work with their pharmacy partner to craft whatever they want to identify how they think they're going to get savings. So this is not something I would tell them. This is something they would say, we want to do this. How do we get there? So in my model, and this is kind of a standard model, but it can be changed to anything an payer wants. So number one, the insurer or the program sponsor pick something that they want to measure, and they think if we can improve this outcome, it's going to help us as the payer. So whether it's diabetes with hemoglobin A1C, if it's measuring blood pressures, PDC is an example, is a number that tells how well patients take their medication every day. There's actually a way to calculate that on a drug by drug basis. So what do they want to do? There's an Elevance total cost of care. So the insurer or the program sponsor is going to pick what they want for a target. Okay, that's step number one. What are we looking to do? Number two is establish a fee-for-service model to pay the pharmacist, which is what our bill here is today is talking about. We're talking about two here. Okay, we're going to pay those pharmacists for those interventions. Again, credentialed pharmacist working on a specific goal that they found in number one through disease state management of drugs. Okay, so the pharmacists are the specialty in drugs. They're going to work with the patient and the physicians and the prescribers to reach the goal, whatever the goal is that the insurer wants. And that's what our bill here is talking about, is number two. But how do we make that valuable and saving money to the healthcare system? We add the value, the VBC, the value-based contracting part, which is 3 and 4. So we pick a performance target. So in my goal, I said, let's make it simple. We want a group, an insurer who wants to identify patients who have out of control blood pressure, and we want to make a target of, we're going to get their blood pressure to 140/90. Again, arbitrary target, I made it up, but any goal, if they may, so then we say, well, let's pick a threshold. Now here's where the payments come in for performance, and here's where the pharmacist and the plan are both incentivized to make this work. And you can do this two ways. You pick a target threshold. So a percentage of actively engaged patients, so those patients identified by the insurance who make the goal. Or maybe is it half of those patients, that's a threshold. Do we need to, does the insurer want to get to 75% or 90% of those patients? Again, all not determined by the pharmacist, determined by that health plan working with the pharmacist to reach a reasonable goal. And so we pick our threshold, and then we say, okay, well, the insurer is identified that we think if we can get this number of patients to this goal at this threshold, we're going to save this amount of money. And we're willing to take some of that money, not all of that money, because we want to save, the pharmacies want to save the insurer money too. We'll take some of that money, we'll put it in a pool. And based on the thresholds that you see in 3, we'll pay that out by performance. So you measure, pick an evaluation period. If they want to do a measurement quarterly and pay part of that money every quarter, if they want to do it annually, you know, whatever the goal is, and they do the reporting, and all that reporting is going into the insurer. And in CPSN, we can actually provide some of that reporting to them for our aggregate pharmacies. So it's not a separate report for every pharmacy. We can provide that. You know, that's just one thing, one advantage of CPSN, but it certainly can be done by anyone. And then decide, you know, based on the performance thresholds in 3, we're going to make out that payment at that interval. So if we go down a little more, and I'll give you an exact example. So again, number 1, what are we going to measure? In this example, we're measuring blood pressure. We want to achieve a goal of 140/90. And pharmacies are going to, every time, they're going to set up a discussion about, we're going to have these patients come into the pharmacy, do a blood pressure, and it's going to get reported, whatever it is. It's just going to get reported as part of that e-care plan. And how is it billed? It's going to get billed for the fee-for-service part of that. So that patient interview, that working with that patient, checking their blood pressure, reviewing the meds, any intervention that needs to be done, that's the part that's going to get billed under our bill here today using a CPT code. And as I had mentioned, we looked at some based on what the American Pharmacists Association thought. And these are not pharmacist specific, but they're the same codes. 99605 is a code that another provider would use. In our example, we put provided by a pharmacist. So if we go up a little bit more, you'll see, so these codes are medication therapy management. If we go to the next, a little farther, these codes are for these are different codes for CPT codes for evaluation and management of a patient. They're standard codes, nothing we're making here. So we get to that performance threshold and bonuses. So here's an example. So in my example, the program's set up so that when the patient meets the goal during that, whatever the measurement period, there's a $60 payment to the pharmacy. And as our thresholds go, you can do it as a bonus model or a penalty model. Personally, I think bonus models incentivize, and it's you get better performance on anything if you do a bonus rather than a penalty, but that's my personal opinion. But in my example here, so if we have 200 patients in this pool, right, sent by the insurer, if 80% or greater of those patients are improved to our goal, the bonus of $60 gets paid. If we don't get quite the the result that the insurer wants, well, 60 to 79% meet goal, they only get half of that bonus, $30. If we're at less than 60, I mean, I put 40 to 60, but if it's less than 60, well, you didn't meet the goal, you don't get a payment. Same thing, flip the other way around as a penalty model. You know, if 80% are engaged, there's no penalty. If 60% are engaged, there's a 50% penalty. It's the same thing, just wording it differently. So the point of this is it's not made by the pharmacy, it's made by the insurer. So they're assuming if we can do this, there is no fiscal note because it's going to save them money because they're looking at their analytics and thinking that it's going to save them money, and they're going to pay the pharmacies, but they're only going to pay them if the network of pharmacies that they're using meets the goal that they want. Does that make sense to everybody, or any
Yes,
questions?
it does make sense. Is this being implemented elsewhere. Okay.
And this is one of hundreds of different kind of programs that can be done. Again, addressing different payers. Maybe it's a self-funded plan. Maybe it's a Medicaid program. It's, as I mentioned, the Elevance was Medicaid managed care program. So that's not here in Connecticut. We weren't eligible to participate in that. But it could be done, the program is designed based on what the insurer is looking to do, no matter who the insurer is.
So I'm jumping a little bit ahead on the deliverables for next meeting. We did talk about OFA reporting, and you're countering kind of with, this. Do we want to have, and I'm looking over at Sue, do we want to have someone present this value-based arrangement from another state?
I think Ed did a really good job on it. I feel like I understand. Go ahead.
So I can bring in national speakers.
Okay.
There is a gentleman, I haven't asked him, so I can't vouch for him, but there is a gentleman that runs credentialing and these kind of programs from the pharmacy clinical side. He has a business that does that. And
Okay,
he's
you-
working in many
We
states.
talk offline, then we'll talk after.
Madam Chair?
Yes, Representative Meskers.
Sorry, I literally had someone come to my door when I was up to speak, which is why I couldn't get off the mute. So I want to frame it from where I'm understanding the dialogue and the conversation going. We're looking to broaden the scope of practice potentially for pharmacists. Where the business model we're using is value-based. And to be explicit on that, we're going to provide the same payment for the same service across the scope of providers. So whether it's a doctor or a pharmacist or a physician's assistant, for the procedure involved, it's the same reimbursement. And what we're hoping for and expecting is the insurance companies come with a model, a value-based assessment of the provision of the service, and that they're willing to broaden the scope because it drives down future healthcare costs with improved outcomes. I've heard iterations of that in almost every aspect of our healthcare industry for the last 4 years with rising costs. So I'm going to be looking at where those systems and value-based are actually having an incremental cost or savings in premiums and outcomes at different parts of the country in terms of the resultant expenditures. Because again, if I broaden the scope of practitioners and leave the pricing for the same for every practitioner, unless I limit who gets paid, I'm going to broaden the scope and potentially increase premium costs in a cycle that I'm concerned about. So I'll be looking at I want to understand those value-based outcomes. And I'm not saying that I don't believe, but if the value outcomes in morbidity, healthcare costs, issues with the patients that are going to be treated, if there isn't a material decline, we may be improving outcomes, and I'm not adverse, but we need to understand that we may be having a significant impact on premiums, and that's my concern.
Thank you, Representative Meskers. And just to clarify, we're not talking about scope of practice. We're talking about how to reimburse pharmacists for the work that they do, and defining what, learning about what those services are, and talking about a payment model, talking about, the credentialing and those. It's not about the scope.
Okay, perfect. Thank you.
Okay, so why don't we move on to credentialing, and we're going to keep it short and sweet, and then we'll talk about what we're going to do for the next meeting. I would like to pass this over to someone that can speak better than I can on credentialing. Do we have any takers? I'm going to look online and see if anyone raised their hand to save us. No one did. Ed.
I'm sorry. So I'll make my point of credentialing short and sweet. So it's an outside program. It's not pharmacists credentialing themselves. There's different agencies that do it. The one that I would look seriously at is a group called Pharmacy Profiles. They're a company that's an independent company that's set up by the American Pharmacists Association. So it's a professional pharmacy organization, and their goal, all they do is credential pharmacists. So basically, they go through the background very similar to each state. We have to have certain things every year. We have to put in Connecticut. We have to do 15 hours of continuing education and file that attestation with our license. Well, a credentialing agency goes through a myriad of things for the pharmacist to make sure that they're capable of doing this, and they bring it all into one repository. And then an insurance can access that repository to verify that the network that they want to use meets the credentialing criteria in the country. So I'd recommend we look at pharmacy profiles. They are NCQA certified. So that's the credentialing agency. There are others out there. Acorn is another one that's out there. There are some other ones out there, but Pharmacy Profiles credentials pharmacists. So as Susan mentioned, sometimes other credentialing agencies see pharmacies because there is no standard across the country. It's hard to credential. Whereas Pharmacy Profiles, in my opinion, we can look at whoever we want. They understand the world of pharmacy. And so they're a good source. And that's what a lot of the value-based contracting around the country is using them to credential pharmacists.
All right, anyone want to add to that? Okay, so why don't we talk about, we talked about a lot of things that we'd like to work on for the next meeting, and we did inundate everyone with reports and stuff for this meeting. So all that, just because we sent that and, briefly reviewed those doesn't mean we can't come back and revisit. So you guys are leading this, discussion on how we move it forward. So one of the things I wrote down was the Washington and Texas laws that I keep hearing a lot of those states come up. And would it be something that I could reach out to an insurance department in one of those other states to talk about their implementation of their law? Is that something that would be helpful? No. Or maybe I could just reach out and see if they have a bulletin or a report posted on. I can look up that. We talked about a lot about the value-based payments, and I think we need to dive into that and just keep exploring that. Ed, you and I can talk offline about some speakers potentially to come in. I think it's always good. I mean, I'm learning so much, and it's a lot of information. So I feel like the more information we have at our fingertips, the better we will be in coming up with a, report and direction at the end of this. Any other deliverables that we referenced today that I missed? Matt?
Thank you, Madam Chair. I think similar to what you were kind of alluding to, I would like to further investigate some language on the non-discrimination clauses that we brought up. I think it was C. Well, not a mandate. I think the word allow was used. I get a little worried that loses durability, and I would just be interested in hearing some of the verbiage from other states.
Great, thank you. Is there a reason why it's so echoey when? Okay. Great. Any other issues, topics? Okay, so we have our marching orders for our next meeting. Do we have a date and time picked out? Okay, so let's look at our calendars. And I think we're doing about the third week of the month. So that puts us at either September 15th or the 22nd. We can stick with, what's today, Wednesday at 11? Tuesday? We can stick with Tuesdays if that works, or we could work on a different day. Tuesday the 16th or Tuesday the 23rd? 23rd, yeah, I think we need a little bit of. Oh, 23rd is Rosh Hashanah. What about if we did the 24th, Wednesday the 24th? It is, okay. How about Wednesday, the 18th or Wednesday, the 17th? I know that's very soon after Labor Day and everything being a little crazy, but I think we can handle it. Sound good? All right. Wednesday, the 17th at 11 a.m. And Allie will get that out on our calendars, and she'll also yeah, we don't want to do it on that day. There's a party on the 17th. We'll all get an invitation. We just learned. Okay. What if we looked at the last week in September, the 30th? Tuesday, the 30th? Okay. Tuesday, September 30th, 11 a.m. Allie will send out the calendar item. And anyone, I know we're sending a lot over email, so if you need access to some of those. Okay, we'll just keep it. All right. Anything else? Great. Thank you, everyone. We'll see you in a month.